In this lecture, we will talk about diseases of the immune system. I will upload this into YouTube and you will find important chapter links down below in the comment section. These are the objectives of this presentation. The presentation here should be studied in conjunction with the sway on the pathology of the immune system that is linked from this slide, which should be on the PowerPoint deck that you have received. Let's begin with an approach to the patient with immune disorders. Patients with immune disorders have numerous organ system involvement. Because of that, uh, it is imperative to understand that there is no one set of symptoms or signs that you can encounter. It is truly disease specific. Regardless of that, there are certain commonalities which include deformities that happen because of the joints slowly wearing out, and there's weakness or fatigue, which is almost constant, and there is possibility of secondary infections. So a study tip for this reason is by the end of studying for diseases of the immune system, can you explain why do patients experience these clinical manifestations of each disease? If you can do that, then you basically have your map or your guideline to approach these patients. In looking at gender prevalence in autoimmune disorders, we can see that 1/3 of risks for developing autoimmune disorders is heritable, including the preponderance of one gender versus the other. Autoimmune disorders account for 75% of approximately 23.5 million people having autoimmune disorders in the US. The uh, the prevalence of high death and disability is paramount in this population. The reactions that are seen in autoimmune disorders are more vigorous in females than men, and it does fluctuate with hormonal fluctuations. Uh, there is certainly a health disparity because women's health issues affected by AI is significantly more than men. Now let's look at the diseases of the immune system. So we get diseases of the immune system when the system either has an exaggerated response, so it does more than what it is supposed to do, or when it starts attacking the body of the host or the person itself. We also get autoimmune disorders when there are conditions in which the immune system is underperforming. It is not doing enough. And of course, if there is any of these features, then it leads to perhaps an inflammatory reaction or a response. So all of these things are features of immune disorders. There are conceptually four different types of immune disorders. Immune reactions that can cause injury, and such reactions are usually the hypersensitivity reactions. Then there is the disorder of failure of tolerance to someone's own antigens. So antigens of their own body um, is unable to recognize themselves, and these are your autoimmune disorders. Diseases due to defects of the immune system, and these are seen in the immunodeficiency disorders. And finally, disorders of immunity and inflammatory disorders. So these are four different classes of disorders that you can see. Let's look at the first one of them, the hypersensitivity disorders. So hypersensitivity is defined as an exaggerated or inappropriate response of the immune system in reaction to a pathogen or an allergen. There are two ways to classify this. It's either an immediate or delayed response, and we can classify it by numbers, class 1, 2, 3, and 4. Some overlap does exist between these classes. Let's look at what is type 1 hypersensitivity. It is defined as a rapidly progressing immune reaction brought about by an antigen binding to the surface of IgE coated basophils or mast cells. Now, simply spoken, these are violent reactions to a triggering incident and is potentially fatal due to the release of powerful biologic mediators. These are usually mediated through immunoglobulin E, and it leads to a localized reaction called anaphylaxis, which includes respiratory allergies, which is perhaps the most common type. So the most common of all the allergies is hay fever, which affects about 10% of the US population. Other disorders such as asthma and food allergies are also type 1 hypersensitivity reactions. So type 1 hypersensitivity is seen or shown on this slide. There is a Ig secreting plasma cell, which you will recall is a basophil that has been uh, that has been activated by becoming a plasma cell. And this IgE, immunoglobulin E, binds to basophils or mast cells as shown in the middle of the image. And then that leads to degranulation of the mast cell, and that releases vasoactive mediators that trigger inflammatory reaction. So the pathology of type 1 hypersensitivity involves what I just showed to you previous screen. And once the vasoactive amines and other chemical mediators like cytokines are released, there is localized vasodilatation, there is edema of the local tissue, which is swelling, and then there is constriction of the local smooth muscles, which perhaps explains the phenomena of asthma where the airways constrict. So that is type 1 hypersensitive reaction. Type 2 hypersensitivity refers to situations where autoantibodies, which means antibodies that attack the own cells of the host and eventually cause destruction of the same cells. The immunoglobulins, those antibodies that are most involved in these kind of reactions are IgG, immunoglobulin G, and IgM, immunoglobulin M. The example of such reactions are hemolytic idiopathic thrombocytopenic purpura, This is a blood disorder, but it is mediated by an immune mechanism where the blood cells just break down. And then there are hemolytic diseases of the newborn and incompatible transfusion. So, if you remember from your blood transfusion class, the fact that if there is mismatched blood given to people, it just breaks down. And that is mismatched transfusion. So, that is a hypersensitivity type 2 reaction. Hypersensitivity type 3 reactions are immune complex mediated disease where IgG and IgM bind with antigens which are deposited in the tissues. So the disorders that you see are based on which tissues these immune complexes are deposited in. So if it is deposited in the joints, it leads to disorders like rheumatoid arthritis. If it is in the skin, it causes urticaria. Kidneys, it causes nephritis. Of course, there are other causes of nephritis, but this is the hypersensitivity autoimmune kind. Then there is pleuritis, pericardium, pericarditis. So these are tissue dependent. On wherever these immune complexes are deposited, you get these reactions. Now, type 4 hypersensitivity is a cell mediated hypersensitivity, and it's usually delayed, which is 24 to 72 hours uh, after the original event. So the reason tissues get destroyed or uh, tissues get damaged or destroyed in hypersensitivity type 4 reactions is because of T lymphocytes, so cell mediated attack on tissues. This type of hypersensitivity is usually seen in in solid organ transplants where there is rejection of the organ that is being transplanted, in liquid cell transplants in which the foreign transplanted liquid, usually blood or blood product, destroys the tissue of the host, and that is called graft versus host disease. And we will learn more about that in organ transplantation. Also, in situations like contact dermatitis, where we see again delayed hypersensitivity reactions. So, these are examples of hypersensitivity when described in terms of class. So, what are clinical manifestations in hypersensitivity disorders? One more time, it is summarized in this slide. I will let you read it and conceptually understand it without trying to memorize. Let's now look at the next kind of immune disorders, which are autoimmune disorders. So, what is autoimmunity? Autoimmunity is the immune response against the body's own antigens. Interestingly, normal, healthy people have mature, self reactive lymphocytes in their tissues, but they do not develop autoimmunity. Autoimmunity is the breakdown of the regulation of these self reactive lymphocytes, which means there is a loss of self tolerance, and that is the hallmark of autoimmunity. So, to be considered an autoimmune disease, the condition must satisfy the so called Witebsky's postulates. These postulates involve direct evidence from transfer of disease causing antibody or disease causing T lymphocytes. So, also, there should be indirect evidence based on reproduction of the autoimmune disease in experimental animals, circumstantial evidence from clinical clues, genetic evidence suggesting clustering with other autoimmune disease, and autoimmune diseases by themselves uh, are technically incurable, and these are all part of Vitebsky's postulates of satisfying autoimmune disease criteria. A little history about autoimmunity. You can see Paul Ehrlich in his 1908 Nobel Prize winning biological theory, Horror Autotoxicus, talks about autoimmunity as far back then. In 1950s, Noel Rose first demonstrated autoimmune mechanisms. And it was another 10 plus years, which is well into 1960s, when autoimmunity got fully accepted as disease. Why is it important to know history of a disorder? The, the, the discussion is deep, but I want you to see how it takes time for science to evolve. When new diseases come through, it actually is when new diseases really occur, it is so interesting when people say science advisory changes rapidly. It is because science is evolving, and it takes time for science to fully understand a condition. This is where you see the example of how autoimmunity took quite a while to be fully recognized into medicine, and yet when we deal with newer diseases such as COVID 19, people think, oh, why is science changing? The reason it is changing is we are still learning about that disease. Okay, so general characteristics of autoimmunity. About 2% of the American population have an autoimmune disease which have either organ specific manifestations or systemic manifestations. So organ specific manifestation means you can clearly make out dysfunction of an organ when it is involved, whereas systemic manifestation is things like fever, malaise, feeling of weakness or fatigue. These are systemic manifestation, and you cannot tell what organ is contributing to it. Now, a low level of autoimmunity is present all the time in normal people. This autoimmunity is essential for you to fight off the tendency of getting into cancers. For example, our body is constantly developing cancers, and yet we do not have clinical cancer. The reason is the body's cellular immunity, such as the CD8 plus T cells, will go ahead and kill these cancers. So, this immunity is always there to protect us from developing harmful diseases. Obviously, one of the reasons we do develop cancers and other disorders that actually can are where the immune system fails to do what it is supposed to do. So we do have, normal people do have a level of autoimmunity, and that autoimmunity is good. It is the amplification of this autoimmunity that causes these disorders. The common signs and symptoms of autoimmune disorders, and it says here for 2017 because the slide was first put in there in 2017. There are numerous signs and symptoms. Again, it is organ specific, and it does have correlation with the specifics of the disease pathophysiology. There are three characteristic pathological effects, however, that is categorized as an autoimmune um, clinical manifestation. One is that there is damage or destruction of tissues. Two is that there is altered organ growth. And then three is that there is an altered organ function. You can remember from previous discussion that the epidemiology of autoimmune disorders is more in women than in men and is the leading cause of death in women in the US up to 65 years of age. There are more than 80 illnesses related to autoimmunity. Again, the general features of autoimmune disease is that they are chronic with relapsing and remitting. They so it has periods of quiescence and then periods of exacerbations when it rears its head and becomes really inflammatory and active. The damage in autoimmune disease is not is chronic and it is progressive, and clinical and pathologic manifestations are determined by the underlying disease. There are recurring thoughts that are perhaps a little bit repetitive, but it just hopefully gives you the impression that by the end of this course, it just sticks with. So, what triggers the body to lose its ability to control the immune system? So, there can be either internal or environmental triggers. Internal triggers include translocation, where local substance released into another area due to internal trauma, or normal body component is altered by perhaps a virus, or less commonly, a foreign substance resembling a natural body tissue gains entry into the body. On the environmental trigger side, you can have biologic agents and chemicals and metals that can trigger these reactions. There are two types of autoimmune disease. Again, this is a repetition because you've seen it before, but specifically, there is organ specific autoimmune disease, and these affect a given organ, and the disorder or the clinical manifestations of the disorder are respective to whatever organ is going into dysfunction. On the other hand, systemic autoimmune disease affects a wide swath of organs and therefore gives rise to symptoms or signs which uh, can affect numerous organ systems. So this slide shows you the the organ-specific autoimmune disorders that affect perhaps one organ system. And then it may have a cascade of related organ systems that also get affected, but regardless, these originate in one organ system. For example, diabetes occurs in the pancreatic beta cells from where insulin is released. Graves' disease has to do with thyrotoxicosis, so thyroid hormone. Myasthenia affects the myoneural junction or the motor end plate. Multiple sclerosis affects the central nervous system. The disorders indicated by the check marks are specifically important for you, both for my course as well for the boards. Therefore, when you go into the SWAY, you will find more details there about these two specific diseases, and you must inform yourself about the clinical course, the, the pathophysiology, clinical course, clinical manifestations, all of those in that SWAY. I do talk a little bit about the other ones here. At least you should know which organs are being involved. definitely find out the definition of good pasture syndrome, and so on. In the previous slide, I forgot to tell you that you should also look at diabetes mellitus, because diabetes, even though we are mentioning it here, is also relevant to you from the standpoint of hormonal endocrine disorders. It's one of the most important disorders to know for your exams as well as your clinical practice. 9. Systemic autoimmune disorders, which are shown on this screen. You see these disorders affect the entire body. So these are multi-systemic disorders, affect more than one organ system, and uh, leads to a wide swath of clinical presentations. They are all important. Really, I cannot tell you not to look at it, but some of the important ones I put check marks in, and if I did not, then even then you should look those up, at least by definition and basic understanding of the disease. So you see these ones, you should know about when you go into the sway. On the top left is a disorder where you see trying to figure out which one is this showing you. Can't remember what this one is showing you, but it is most likely hemolytic anemia. So where the blood cells are breaking down. On the bottom left is Graves' disease, which happens from thyrotoxicosis. And on the right, this feature is pretty characteristic of systemic lupus erythematosus, SLE. Look at the rash on the woman's face. There these two wing-like projections on the malar eminence of the cheeks, and these wing-like projections is connected by a bridge over the nose. This is called a butterfly rash, and it is characteristic of systemic lupus patients. Okay, so what are some treatments in autoimmune disorders? The treatments, there are primary management and secondary management is rehabilitation. That is it. That is the role of rehabilitation. Secondary management. The primary management suppresses the disorder. These disorders are not curable, so it can only be suppressed and it's medical in nature, but secondary management involves rehabilitation. So these are some medical treatments for autoimmune diseases. I'm not going to go into the details of it. The secondary treatments, which is related to rehabilitation, I will just give you a broad 30,000-foot overview. The challenges faced by these patients are specific to the condition. So if you don't know the condition, you don't know what to do about it. So the more you inform yourself, the more you know what tissue damage they are undergoing. I'm not going to be able to cover that in class for you, but I do expect you to know those disorders that I checked off for organ specific as well as for system specific disorders, especially the checked ones. Now, when we have these disorders, obviously you saw primary management being medical. But medical management, as you know by now, is not curative. It is just suppressive. That means that those drugs cannot achieve full cure. And on the flip side, those drugs have significant side effects. And patients who need rehabilitation may also need management of the side effects of those medical management. And therefore, if you don't know the medical management, then you don't know what side effects they undergo. So, again, that should tell you how much in depth information you need about these conditions. I'll leave it at that. And the onus of learning passes on to you. Okay, let's look at the flip side. We have been talking about disorders that are caused by a hyperreactive immune system up till now. Now let's look at what happens when there are immunodeficiency syndrome, the flip side, when the immune system is not working up to the mark as needed. So immune deficiency disorders can be classified into two uh, broad types: primary disorders and secondary disorders. Primary disorders are ones that we inherit. Okay, these are congenital, these are rare, and more than 95 inherited disorders fall into this class. However, secondary disorders, the ones that are acquired disorders, they comprise of some really well-known diseases that we encounter more than the primary disorders. Examples of secondary disorders include leukemias and Hodgkin's disease, and these are actually cancers. Then we have disorders that happen due to steroid treatment, especially corticosteroid treatment, other medications, radiations, and chemotherapy, and also in conditions such as alcoholism and acquired immunodeficiency syndrome, such as uh, the one that is caused by HIV or human immunodeficiency virus. Perhaps AIDS is the best known immunodeficiency syndrome. So again, some select immunodeficiency syndromes involve AIDS and deficiency syndromes that is caused by medical suppression of other immune diseases. What do I mean by that? Just to clarify that. So when we try to suppress immune disease, we may over suppress, and that can lead to an immunodeficiency situation. Some factors that affect immunity are listed here. So there's numerous factors that affect immunity. You can just pause this and refer to your slide deck for more information. Now, factors that increase exposure to pathogens that can trigger or immune disorders can be iatrogenic. For example, iatrogenic word means disorders that are secondary to an underlying medical treatment. So something was trying to be treated, and it is a noble cause to try to treat something, but it causes a secondary impact, and those can be seen in this. For example, urinary catheters. Uh, Urinary catheters can cause more infection to come in. Nasogastric tube. In fact, any indwelling line or tube can cause exposure to pathogens that can trigger an immune mechanism. Also, sexual practices such as having multiple partners and lack of protection are other ways to get exposed to pathogens that can trigger immune reactions. We will have to briefly touch upon age-related changes in immunity. This is important in many ways to appreciate how immunity changes with age. It's also required by CAPT that you know this. So, age causes changes in the body. There are various theories on what causes these changes. The most prevalent theory is the oxidative or free radical theory of aging. Um, and it tells us that both innate and acquired immunity change over time. And I have given you literature to review to inform yourself about this particular age-related theory of, sorry, oxidative theory of aging. I will leave it at that. These are some of the changes that happen to the innate immunity with age. Skin thins down. Okay, so older people have thinner skin. There's decreased acidity in the GI tract. The breathing gets shallower. There's less acidic urine. And you remember, urine is acidic. It helps in cleaning off your urinary tract, and so on. So you see all these changes that is happening to innate immunity. Changes to acquired immunity over time includes the ones that are shown on the screen here. The thymus shrivels and the T and B cells decline in production. And there are other related changes that is on page 250 of pathology textbook. You should read that and inform yourself. Let's look at exercise immunology. You you should see that with exercise, initially there is a stimulation of the immune system, but if you keep on exercising for a longer period of time, the immune system typically dampens, it goes down, and you lose the ability to fight viruses and bacteria and other pathogens. The typical recommendation is that do not overexercise patients who are actively either demonstrating infection or a very um, active phase of immune disorder. So again, this slide explains it that the moderate amount of increase in immune function is seen with initial exercise, but if you get into maximal or severe exercise, the immune system actually dampens. The immune immunity ability decreases. The immune system needs about 6 to 24 hours to recover from severe amount of exercise in normal people. Now, while intense exercise is known to cause immune suppression, there has been no literature evidence to demonstrate detrimental changes on immune function or rate of infection in the frail or elderly. There is something what we call a neck check, which refers to if the symptoms are above the neck, then okay to exercise with reduced or at half intensity. If the symptoms of the disorder are below the neck, then do not exercise unless we are talking about just functional activity like getting up, sitting at the edge of the bed, going to the bathroom, and things like that. The immune system interacts with the central nervous system. It helps explain how emotional states can influence immune function. The communication is bidirectional, which means the neural and endocrine activity affects the immune function and vice versa. There are two pathways that link the brain and the immune system: the autonomic nervous system and the neuroendocrine outflow from the pituitary gland. When do we refer out to a physician? in cases of autoimmune disorders. Please read page 479 of differential diagnosis text.